So, everybody, this is Dr. Susan Daniel, and I'm going to let her introduce herself. We are just delighted that she has put this presentation together for us. It has taken a lot of work. It has come from years of practice and experience. So I hope you're as excited as we are for listening to her presentation. So Susan, I'm going to turn it over to you now.
Thank you so much. And I am very excited on presenting this presentation. And the topic for tonight is the role of optometrist in spelling communication methods. And a little bit about me. I've been in practice since 1992 with Daniel and Davis Optometry. I've been the immediate past president of the Neuro-Optometric Rehabilitation Association International, which is a group of multidisciplinary professionals with occupational therapists and physical therapists and optometrists working together to help those who have stroke and brain injury. A clinical preceptor for fourth-year optometry students at the Illinois College of Optometry. And I'm teaching students how to do the type of work that I'm doing at my practice, working with special needs patients and stroke and brain injury. I am a consultant at the Tri-City Medicare Center and Scripps Brain Injury Rehabilitation Departments, seeing patients chairside and then working with the OTs and the PTs to develop a program within the rehab department, and then they send them to our practice out of there in acute care. And then I'm a consultant and provider of vision therapy services for San Diego County School District, seeing children who have an IEP. So this is my inspiration and my speller, my son, Matthew, and he is a new speller, meaning that he is spelling to communicate using a letterboard. And I'm so excited about his progress that I wanted to share this with you. So the course topics that we're going to go over are the terminology, what is an AAC, the types of assistive technology, what is Praxis, what is spelling as communication and the research behind it, the Skeffington's model of vision, a developmental vision exam and how I prepare for it, and a sample exam protocol for a speller, and different techniques that I use to help the patients get used to the sensory problems that they may have with wearing glasses, and some case studies of exams and vision therapy for spellers. So first, I'd like to go over what is speech versus language. Speech is 100% motor. It's the ability to communicate thoughts and emotions by articulate sounds. And it includes how we make sounds with our mouth and our lips and our tongue, and how we use our vocal cords and breath and our rhythm of speech. Whereas language is 100% cognitive. It refers to the words we use and how we use them to share ideas and get what we want. It includes what words mean, how we make new ones, and how to put words together, and which words are appropriate for a social situation. So speech is motor and language is cognitive. What's the difference between nonverbal and non-speaking? Nonverbal, the word means without words. So nonverbal communication is covering and exchanging methods without the use of words, such as our posture, our facial expressions, gesture, and expression. But nonverbal implies that a person does not think with words. Whereas non-speaking, a person who is non-speaking may use words in a way other than that, like oral speech, such as writing, spelling, and reading. So what's an augmentative and alternative communication? AAC means all the ways that someone communicates besides talking. Augmentative means to add to someone's speech, whereas alternative means to be used instead of speech. An AAC could be a method, a device, multiple strategies used for communication. And people of all ages can use AAC if they have trouble with speech or language skills. So an unaided communication system is one that relies on the body's language. So using gestures, eye gaze, vocalizations, and sign language. Whereas aided communication systems can be low tech or high tech. A low-tech example is using the letterboard or picture exchange communication system, whereas a high-tech is using computerized keyboards, digitized synthesis speech, and eye gaze technology. So what is the assistive technology device definition? An assistive technology device means any item, piece of equipment, or product system, whether acquired commercially off the shelf, modified, or customized, that is used to increase, maintain, or improve functional capabilities of children with disabilities. So this is the picture card exchange communication system. This is a system that my son, when he was younger, used to express his wants and needs. And so what he does is there's an icon that has the beginning of a sentence, such as I want, I hear, I know, I need, and he selects that icon and puts it on a sentence strip, which is below in the yellow. Then he takes another icon of what he wants to do. So say he wants to bounce on a ball. He'll take the bounce on a ball icon, pull that off and put it next to the I want icon. Then the sentence says, I want to bounce on a ball. He takes that sentence strip and exchanges it with his communication partner. And that's where it comes with that picture card exchange communication system. There are also iPad apps such as Touch Chat and Prolo Quota Go, which are using that same type of thought where there's icons that it can express feelings and wants and needs and what things they want to do. And they use the same thing where they put I want, and then they can select an icon, I want markers, and then it will speak what you have written. So it'll say, I want markers at the top and speak it out loud. Then there's some sophisticated electronic devices, such as the one on the left, that is purely programmable to all of the needs and wants that the patient would like to speak, that are the most common. It also has the ability to type to speak as well. The technology on the right is a modified keyboard that it has different size letters for those who are speaking, who may have low vision or difficulty with finding the letters on the keyboard. Then there's eye gaze technology, and this uses our eye gaze to look at either a letter or icon that is on a screen, and it sees how long that you look on the said letter for 2 seconds, and then you go to the next letter, then the next letter, and then it spells out what you want to speak. And this is good for patients who have difficulty with using their hands, such as patients with ALS and Rett syndrome. And this is the type of low technology aided communication system, which uses a letterboard for spelling or typing to communicate. And this is what I'm going to be going over more today in my lecture. So using an aided and alternative AAC device takes a multidisciplinary team to help the spellers, such as a speech and language pathologist, an AT professional, an occupational therapist, and an optometrist. So what is Praxis? Praxis, or motor planning, is the ability to conceive, organize, and execute a new task in a sequence of smooth motor actions. It involves both cognitive and motor. It begins with an idea, the plan of how I'm going to execute this motor exercise, the sequence of events that I need to do, and then it switches to motor. How do I initiate that motor movement? How do I execute it and actually do the motor movement? And how do I adapt? So say, for instance, someone is wanting to have an idea that I want to brush my hair. So that's the idea. They make a plan that they're going to pick up the brush, put it on their head, push it down to brush their head. And that's that sequence of the plan. Then comes the initiation of the motor movement. I have to move my body to pick up the brush. Then I have to move my body again to put it against my head and then pull it down. That's that initiation and execution. Then if my hairbrush gets stuck in my head, then I have to adapt to move it to pull it down. So praxis is a brain and body connection. Apraxia is a term that is used to describe the inability to perform a particular purposeful action despite normal muscular strength and tone. Whereas apraxia of speech is a disruption in that ability to produce and or sequence sounds not due to muscle weakness or impairment. So apraxia is a brain and body disconnect. And studies shows that 2/3 of children with autism also have apraxia. So there's 4 types of body movements. There's reflexive, impulsive, purposeful, and automatic. An example of reflexive is if you're touching a hot stove and you jerk back, that is a reflexive motor movement. Impulsive is a movement that requires no forethought, that it is just a movement that is jumping. And so you'll see a lot of these impulsive moves with our kids with autism, with different types of stims and grabbing things. Whereas a purposeful movement is such as used with grabbing that brush, brushing my hair, that's purposeful. And then after doing a purposeful movement over and over and over, then it becomes automatic, such as driving a car. So spelling as communication is an educational model, training, and curriculum used to instruct non-speaking, minimally speaking, or unreliable speaking students to spell or type to communicate. So this method uses an AAC device, which is a letterboard or keyboard, to utilize purposeful motor movements to communicate. We have a communication regulation partner, which we call a CRP, which is someone who regulates, coaches that motor for the speller, and leads that person to become an autonomous communicator, meaning that they are able to use the device on their own without the help of the CRP. When you are using this device, you always want to presume competence in the speller, meaning that you presume that they are intelligent and that they are able to understand what the lesson is about and able to spell. You want to teach age-appropriate lessons. So say my 25-year-old, you wouldn't give him a lesson that is for a 6-year-old. So there's a lesson sequence that CRPs use to spell for communication. The CRP first reads an informational lesson to the speller. And during that lesson, the CRP spells and writes down important words that are in the paragraph. The speller is then asked to spell some of those known words that were written down and highlighted. And then the CRP helps coach the motor in order for it to get the speller to start and initiate that motor movement to start to spell on the letterboard. Then the CRP asks a question where the answer is actually in the paragraph that was just read. And then the CRP asks a question related to the topic where the answer is not in the paragraph, such as knowledge that the speller has known from prior. Then the speller moves on to open-ended questions where they spell their own thoughts and ideas. Then there's a sequence of spelling according to their motor demand. As you saw in a picture before on my initial slide, there are 3 letterboard stencils. A speller can use a pencil to poke within the stencil to indicate the letter that they want to use to spell with, or they can use their pointer finger. The 3 letterboards can also be foam boards, where it's a board that has foam letters, or high contrast boards. Then it progresses to using one letterboard that has all 26 letters on it. And the speller can also choose whether to poke it with a pencil or use their pointer finger. Then it goes to a letterboard that has the stencil with a backing, a foam board, or a laminate with letters. And that requires that look and touch. Then we go to typing on a keyboard, but the keyboard is held by the CRP and helps still with coaching the motor when we're first learning how to use that keyboard. And then it becomes to an autonomous independent typing where the keyboard is on a dock and they're able to touch the letters on the keyboard to spell, to communicate. And the goal is fluency, that ability to spell or type open-ended communication accurately, smoothly, and with flow and rhythm on a letterboard or keyboard with ideally at least 2 different communication partners. So here is a video of a fluent speller who is using a letterboard with a pencil, and he's answering a question, an open-ended question that the CRP is giving him. And then I wrote down below what he is spelling.
There are aspects of daily life that are not satisfying to you. If so, please explain. Ready? I-D-O-N-T. I don't. L. Keep going. I. Keep going. K. I don't like. I don't like how little what. A little what? D. E. C. I. S. I. B. Be decisive. C. Keep going. O. Keep looking at the word. C. O. I got the O. Boom. Decisive. C. O. So I got the O, buddy. Keep going after O. N and T and R and O and decisive control. I. H. A. H. A. B. Keep going. I have O. Keep going. B. Keep going. E. Over. M. Y. Over my. R. L. I. F.
And then E.
Other.
So some wonder, is it the CRP that is moving the board in order to spell what the CRP wants them to spell, or is it the actual speller who is spelling? And so they did a research study where they took some fluent non-speaking spellers to wear glasses that have eye gaze technology. And what they were looking for is that when the board is presented in the same spot, are they able to look at the letter with their eyes before touching? And so what they found that the looking at the letter was accurate and shows that it's not the CRP that is doing the spelling for them and doing their own ideas, that it is the speller themselves. So when we look at sight for these spellers, there's a higher than average incidence of refractive errors in people with autism and other developmental disabilities such as cerebral palsy. When they did a study of autistic children, they found that 44% of them had significant refractive error. So then we're looking at what is vision. Vision was first described by Skeffington's 4-circle model, and it has 4 different parts. The first one is the anti-gravity circle. It represents the patient's ability to know where their body is in space and is used for exploration and movement and organization of themselves within their environment. It describes where am I and where is my body parts in relation to one another. And it's the foundation of vision. And when this ability is delayed, we refer to OTs and PTs to help with their core strength, their body control, their bilateral integration, vestibular laterality, crossing midline, and so forth. And that person needs to know where their body is in space in order for them to eventually direct their eye muscles to fixate, track, and work together as a team. Then there is the centering circle. It represents the patient's ability to know where is it. After developing the sense of where am I in space, next comes the awareness of things that are around them. And it involves our eye's ability to aim both eyes together to form one percept and have depth perception, to localize where it is in relation to that person. Then there's the identification circle, and it represents the patient's ability to determine what it is. And this is where we come into having good sight, such as correcting the refractive error. We want to have the ability to focus on the object efficiently, which is necessary to identify and discriminate the objects around them. Then the fourth circle is the speech and auditory communication circle. And this represents all the ways that we become aware of what we feel, see, hear, taste, smell, and know. It's both an internal communication, our thoughts and our ideas within us, as well as with each other. It is what do I know about it circle, and it includes all visual information processing skills. So vision is described as where am I, where is it, what is it, and what do I know about it? So when an individual has delays in one or more of these four circles, vision is compromised. And as Dr. Skeffington says, when vision works, it leads, but when it is compromised, it interferes. So apraxia is a brain, body, and eye disconnect. So what we see in common visual problems with people with autism is that autistics have difficulty with ocular motor skills, such as pursuits and saccades. They have difficulty with converging their eyes with a near point convergence. They have poor fixation, and their eyes have a tendency for one eye to turn out in an exophoric posture. And also, which is very important, 20 to 50% of those with autism have strabismus. So they definitely need an eye exam before doing any sort of spelling, or just to see how their development is going so that we can treat that. So regarding apraxia and spellers, you always want to assume that the speller understands what is asked of them. The speller may want to do what is asked, but because of that brain-body disconnect, their motor output may not be what their intention is. Those with gross motor apraxia will also have ocular motor dysfunction. And because of that brain-body disconnect, frustration with their eyes and body control can cause that fight or flight response. So now we're going into the developmental vision exam. This is how I prepare for the exam before the exam starts. I first send a developmental questionnaire to the parents to fill out. When they return that questionnaire, I set up a phone history with my student or vision therapist to go over any further questions that I may have regarding the questionnaire. And it gives the time for the parent to go over any questions that they have before the exam, and any ideas that they have to make the exam go smoother. Then I ask for the parents to send a video of their spelling on their communication board, because then I can get an idea of what are they like, what difficulty they may have in using the board, what area of the board are they able to fixate on better than others, and that gives me an idea of what type of tests to do. And then I also request the parents to bring the letterboard with them to the exam, because I use that as part of my examination. So I always want to set up the room so that the testing goes quickly and easily without long pauses. I always like to video record the exam so that I can watch it later and analyze it better. And it decreases the need for me to write down the findings at the time of the exam. And very importantly, you want to regulate yourself. The normal response for all of us is that when somebody is elevated, we become elevated too. So in this case, if they are elevated and dysregulated, you want to do just the opposite. You want to regulate your body, sit down, remain calm, and then allow them the time for them to regulate themselves and to sit down on the chair, become comfortable, be aware of their surrounding before you go to just starting the exam. So you always want to introduce yourself directly to the patient. Now, I've already talked to the parent about most of the history, so we don't need to do that. So when in the history phone call, we say when your son or daughter comes in, we are going to pay all the attention to them. So I want to always introduce myself directly to them and speak to them in an age-appropriate voice. They are non-speaking, but they are intelligent. And so you don't want to speak to a 20-year-old in a sing-songy voice that you use for a 2 or 3-year-old. So here's a sample introduction that I do. I'm Dr. Susan Daniel, and we are going to do many different activities, which I use activities instead of tests, because when they see test, then they're like, oh no, what are you going to do? Are you going to do a shot or poke and prod me? But no, we're just doing different activities that will check how healthy your eyes are, check how clearly you see, and check how you use your eyes to gather that visual information. And this is important so that I can help make sure your eyes are comfortable and that you see single and clear, and that you can use your letterboard easier to communicate. Once they understand that this is why they're here, then they are much more participatory in the exam. So one of my main goals is to decrease their anxiety throughout the exam to get the most out of the exam. And how you do that is you first always model what you want to do before you do it. And what I mean is that, say you're going to use a slit lamp by a microscope and you want to check the front part of their eye. So you're going to bring the slit lamp towards yourself. You put your chin on and you say, I'm going to have you put your chin on this chin rest. I'm going to move the light back and forth, and it's going to look at your eyes, and I'm going to count for 5 seconds, and then I'll give you a break. Then you help when you put it in front of them. I say you can hold on to the handlebars, and I coach them through it. I said, you're going to look at the chin rest, raise your chin and rest it on the chin rest. Now, remember, they're apraxic, and so breaking down the sequence of events to get to initiate that motor movement helps them better to put their chin on the chin rest. Then you can do, if they have difficulty with that initiation, is use a starting command like ready, set, go. Counting always helps because they understand the concept of counting, and the concept of time is very abstract. And so you want to count down rather than count up. So I say, I'm going to count for 5 seconds and look at the your right eye with the light. And so they can hold on for 5 seconds and you go 5, 4, 3, 2, 1 as you're looking. You can count a little slower than that. The reason why I count down is that they know after 1 they're done. Whereas if you count up, they have still that anxiety that you're going to go to 6, 7, 8, 9, 10. Now you can do many repetitions of 5 seconds, but you're giving them that break, before they start to do the activity again. And if you're going to be touching their face, always model on yourself that you're going to be touching their eyelids to move them down so that you can see that before you go to touch them. So here is a sample exam sequence that I have. And I do mix it around a bit, but this is sort of the order that I do for most of my patients. Some of these I'm going to have videos over because you may not have them as part of your exam. But we do, I use pull tubes to look at body strength, check their fixation, binocular vision, pursuit saccades. I use a stick and straw technique that I'll go over. I always check the near point of convergence, both in straight ahead, up gaze and down gaze, because just that simple test can often see whether they have an A or V pattern to their how their binocular vision works. I want to see how they're crossing midline, both motorically and with their eyes. And I check their vergence ranges and vergence jumps with a prism bar or a stick prism. I look at fast pointing and occlusion avoidance to see if they have amblyopia or just like we do with younger children. Look at their reflexes and pupils. And I really rely heavily on my retinoscopy skills to get the right prescription for them, especially if they have astigmatism, because you want that axis to be perfect. Sometimes if they're able, I'll use a topographer as well to help, and auto refraction, and then outside the phoropter and inside the phoropter. What I do with my phoropter is that I have a manual that I keep very loose. And so I move with the student as I'm doing the ret, and you go fast, and then give them a break. You can tell what their anxiety is, and that's pretty successful. I do near point retinoscopy and stereo, color vision, visual acuity, which I'll go over. And then as I'm transferring out of the exam room, I'm checking their gait. And when I get into the vision therapy room, we're looking at Marsden ball, Yoke prism, LaBarge, reflexes, and letterboard testing. So the first test that I do is kind of an icebreaker for them. It doesn't look like a test. But it is checking their motor strength. And so I'm first looking, can they pull the accordion plastic tube towards their body with just their right hand, and then just with their left hand? Then can they do it with both hands together? Can they cross midline and be able to pull at the same time? And can they look up to pull down? So this is Levi, and Levi is using the pull tube. He got the understanding of what I wanted to do. Then I help with his motor and getting his hand to touch it. That's right. That's exactly what I want. Now the next one. I got two of them right. Ready? And you can see that's quite good. Now, when I get to the up gaze, I want you to notice how he avoids that up gaze. Now, what we find in the rest of the examination is that he has a V pattern exotropia, which makes sense because he's seeing more double in up gaze. So just that one test gives you some of that idea. Now, the next video is of Max, and he's a youngster who is very low tone. And so when I gave him the accordion tube, he couldn't hold on to it. His hands were very low tone and he couldn't hold on to it. So I'm holding his hand to give him that prompting to hold on to the tube while I'm pulling it with him. And then I'm seeing, is he able to pull it himself, pulling it apart with two hands? Does he have that strength? And can he pull it from up gaze as well? You a little hungry, sweetheart? Resistance from people. And notice how his whole body, when he's trying to do this, is slumped. We did, after this test, put a pillow behind him to help with his posture so that we can complete the other testing. But I didn't do that in the beginning because I wanted to see how his posture was on its own. And then I'm seeing, as he's doing his motor, can he look and do the motor at the same time? So the first test that I'm doing for ocular motor skills is looking at fixation. Now, there was a study by Dr. Stacy Coulter in 2021 that looked at fixation, comparing the ability to fixate for longer than 10 seconds in typically developing children versus those who are autistic, either non-speakers or unreliable speakers. And they found that 96% of the typically developing children can fixate for longer than 10 seconds, but only 55% of unreliable speakers and 63% of non-speakers were able to fixate for longer than 10 seconds. And I see that in practice too. So these are the observations that I'm looking at for when I'm testing for fixation. What type of target keeps their interest? It's likely not a wolf wand where they're looking at the ball on the stick. They'll look at it for a second and then they're like, okay, I've looked at it. What keeps their interest? Is it an iPhone? Is it a movie on the iPhone? Is it a toy? Is it their letterboard? I often find because they are used to using their letterboard, they say, I want you to look at the letter M, and we're going to count to see how long you can look at the letter M, and that they may do better with that. Then I look at what size of the target elicits the fixation. Can I see a little small target, or does it have to be bigger to keep their fixation? Does the target need to be lit up, or does the lit up with the lights off to where you're taking away that peripheral vision and they can pay attention to that central target? Does the target need sound? Do you need to make it squeak to keep their interest? Does it need to be spinning like a spinning toy? And then we count how many seconds they can fixate on the target. So this woman is 35 years old. She had her first eye exam ever, and she had really no interest other than tearing paper. So she wasn't in a day program or anything that was stimulating because she had really those no interest or fixation. So I want to show you kind of how she's looking. This is the first day that she got her new glasses. She has a +6 prescription, and we're trying to see if she has that fixation. Now I took that magazine that she likes and moved it, and I put it in upgaze to see if we can get that fixation in upgaze. Once we found that she was interested in that, then we used the magazine as a pursuit target, being able to have her fixate while she's walking with the magazine as I'm turning the pages. And then we were able to get to things that were of different interest. So the next skill that we're looking at is the visual pursuits. And we're always looking at the whether they have body movement with their pursuits, whether they have head movement with their pursuits, and how long can they stay fixated on it before they lose that ability to fixate and pursue. Do their eyes lose fixation at midline? Are they able to fixate the target, come to the middle, lose it, and then regain it? That correlates with the difficulty of crossing motor midline. Is there avoidance of a particular gaze, meaning that they can go all the way around, and then when they get to right gaze, they lose it? What is the quality of the pursuit? Do they have many different jumps? And how accurate is the pursuit? So here is Brady, and I want you to look at his head posture as he's doing the pursuit. See, as he's going in up gaze, he moves his entire head up to maintain his vision in primary gaze. And as it goes around the circle, when he gets to right gaze, he loses it with his head. Now I'm going into a smaller target binocularly to see if he can maintain fixation. And he has the same response in difficulty in up gaze and in that right gaze.
That's it. Now this time, remember I held your head last time. Not your favorite, huh?
Now I'm going to hold on to his head, and what I want to see is, can his eyes move in that up gaze even with his head movement. And you see I have to wiggle the target to try to get that up gaze. And so he can do it, it's just that it's very uncomfortable for him to get that up gaze. And he still loses that fixation also in right gaze. So now I'm looking at visual saccades. Is the patient able to fixate on a target on the left, then jump fixate to the target on the right? Do they have full body movement doing that? Do they have head movement? Are they able to cross visual midline to where they're start here, they stop at midline and then go over? Do they avoid crossing midline, meaning that their body is situated here, and then when they switch to this target, it avoids their eyes crossing over midline. I check that both the horizontal, the vertical saccades, and diagonal saccades to see if there's a quality difference, especially binocular, because I want to see, is there an eye turn as well when I'm looking at the saccade? Can they initiate that saccade or release fixation? The difficulty that we see with apraxia is in that initiation of the motor movement. Can they release it? Are they aware of that peripheral target and then jump straight to that? And is one gaze more difficult to saccade to? Is it always that they can saccade from right to left easier and left to right, they don't have that location of finding that right target? Do their eyes stop at midline during that horizontal saccades? And is there a postural change? Like you'll see with Max, who is very low tone, is that he, when we were doing his testing, he had the pillow behind him, he was able to maintain the posture until he did a motor movement, and then his body slumped again. And do they need to touch the target in order to have find the location of the target with their eyes? And do they need that target to have sound, motion, or light? So I use the stick and straw technique, using a stick in a tube or a golf tee in a straw for a lot of my testing, both for looking at binocular skills, NPC, pursuits, and sometimes saccades with 2 straws, looking at retinoscopy, near point retinoscopy, and quite a few different things. So I'm going to show you some videos. The first patient here is Sophia, and she has cerebral palsy. And so I start with a tube in a tube, which has a less motor demand because of her cerebral palsy. And I want to give her something that she may be successful with and not start straight with the stick and the straw. So I want you to pay attention to how her eyes are fixating on the target. And how is she moving her head to find the target?
Bless you again. And this one here.
You can see that down gaze is easier than right gaze. Crossing midline, she's avoiding crossing midline by moving her whole body in that right gaze. And then I switch to the golf tee and the straw. I start in the gaze that she did better with.
There you go. Next time.
She likes that I'm uncoordinated. You get into that up gaze, you see she's using just her right eye and she's moving her head up.
I'm good at finding things. Well, sometimes I got it. There you go. Perfect. Now this time, it'll be a little tricky. Okay. I'm going to hold your head.
Now I'm seeing if she can isolate her eyes from her head. Now she's pulling very strong to try to turn her head to her left to try to put that stick in the straw. And we'll find out a little later in the other videos why that is. So here's Brady again, and I'm first checking alternate cover tests for his binocularity, and then using a prism bar to check verdance ranges. And this is what I kind of developed for checking a non-speaking way of doing the Worth 4-dot test. He touches the diagram that shows either 2 or 3 dots. And then I have another diagram that has 4 and 5 dots. I made the 5 dots like an ESO would look, because I know he has esotropia. Now these are with his new prism glasses, and I want to see if he is seeing single with his new prism glasses and sees 4 dots.
Now when you look up here, how many dots do you see? Is it 2, 3, 4, or 5? Let me show you all 4. Look up here. Look up here, right here. How many dots?
And then we do the test the same, first up close and then in the distance. And it was kind of an on the fly thing that I was thinking of, but I thought would be good for others to try in their practice as well. So this is Brady doing a fast pointing technique. And what I'm looking for is the quality difference first in different fields of gaze. Is he touching right at the tip of my finger? How is he moving his body in different gazes? Then I put the beanbag on his head. As you know, that gives him some grounding of where his head is in space. And it's a little bit more cautious, which is good. And that right gaze is still a little difficult. And in the up gaze, he's using his peripheral vision rather than looking up. And then I put the Yoke prism glasses on. What I'm looking at is he then able to get to that top and right gaze much faster. And then also with the beanbag on his head. And you'll find his accuracy is much improved. So we used the Yoke prisms quite a bit in his vision therapy as a rotating Yoke prism to help better with fixation as well as location of the target and success, and as well as how quickly he can adapt from one perception to another. So looking at the autonomic nervous system, we have the sympathetic and the parasympathetic. So you know, the sympathetic is our fight or flight, where our pupils dilate, we're running from the bear, our heart is racing, whereas the parasympathetic, our pupils constrict, we're resting, we're digesting, and there's a balance between the sympathetic and parasympathetic systems in everyday life. But as I mentioned earlier with people who are apraxic, they tend to be stuck in the sympathetic system and they have difficulty with adjusting into the parasympathetic. So many of them have digestive problems. That's in my questionnaire. They also have light sensitivity because their pupils are dilated. And because their pupils are dilated, they have difficulty with their focusing system. So we check the alpha omega pupil testing. This is different than the swinging flashlight testing or testing for an APD. What we're looking at is seeing how the eyes constrict before they go into hippus, that pulsating dilation. And it should be normal between 8 and seconds that the eye can stay constricted under direct illumination before it goes into that hippus. When you see that it goes into that hippus lower than 4 seconds, that correlates to the autonomic nervous system being out of balance and then being in that fight or flight. And that when that happens, they have a restricted functional visual field or that difficulty with their awareness of their periphery. So we use syntonic phototherapy, which is a type of photobiomodulation, using different colored filters that can balance the fight or flight response. In short, on the red end of the color spectrum is a sympathetic nervous system stimulator, and on the blue end is a parasympathetic nervous system stimulator. So someone who's in fight or flight, you may use a blue filter as one that helps them with that rest and digest. And the goal of the therapy is to balance that nervous system. So this is how I check for color vision. This is my son, Matthew. I use the Wagoner color vision test, which just happens to have a circle on every page. And most of our kids with apraxia are used to matching a circle to a circle or a square to a square because that's been in their education. So I find either a puzzle type piece that's a circle or a piece of paper that's a circle, or I'm using a BIO lens that's broken. Normally you don't use that. to put the to match the circle on top of the circle on the page. And you can tell if someone has a color deficiency because then they're not putting it right on. They're accurate on the circle where they can see where you have, if you have color deficiency, you can still see the circle, but not on the other pages. So these are some samples of how I test for visual acuity. When I'm using the center Snellen visual acuity chart or on a projector, I use this with my fluent spellers who can use their 26 letterboard to look and point to match the letter that's in the distance and at near. I do isolate one letter at a time to make it go quicker. Then once they get to the acuity that is the smallest, then I'll have them read a few letters that are on the line, both monocular and binocularly. For those who are not fluent on their letterboard yet, I use a matching technique where we use the Leah cards, and we have the single card that I first have them match onto the 4-figure card. Then I stand about a foot away and show them one card like the circle and see if they can point to the circle that's on the card, but it's closed. And then I move 10 feet away. I don't go straight to 10 feet. And then I'll do the same thing, isolate one of the figures until we get to one that's difficult. And then I may go a few figures in to see if that's their visual acuity. And lastly, I use the Carter Keeler acuity cards, which is a preferential looking card. And it has different pictures on each page. And it's similar to a teller card, which is, the teller cards have a grading on one side and it's blank on the other side. And you're looking for babies or young children to look towards the grading because that's more interesting than a blank screen. Using that with the apraxic population is not interesting enough for them, and they could care less to look at the grading versus not. And actually the pictures are so vertically far apart that they have to cross midline, which may be difficult for them. So what I like about these cards is that they're vertical. They're using the grading system to where the gradings get smaller and smaller, which correlates to their visual acuity becoming finer and finer. And all you're looking for is whether they look up or down, and it can be a quick up and a quick down. So this test can go very quickly, and it's measured at 50 centimeters. So this is Sophia again, and she is using the Leah card symbols and for matching. And I wanted you to look at binocularly what eye she is looking through.
Yep.
And you
That
can
was
tell when
solid.
she's looking at her mom that that's where she's not able to match the figure. So now that we finished the regular exam, then we're transitioning into the vision therapy room. And I look at what is their anxiety level as they observe the room. I go into the room that has the most equipment in, lots of things to look at and see what is important to them. What actions do they take? Are they grabbing the plastic duck, or are they looking at the thing that has buttons? What do they ignore? Sometimes I have the Marsden ball hanging from the ceiling when I go in and see, do they just completely ignore the Marsden ball that's there? Do they run into it? I'm looking at their posture and their attention, how they're moving through space. Are they spinning? Are they jumping? Are they looking at things very close or just using their peripheral vision? And then we do the Marsden ball sequence. This is a popular sequence that we do. We have them tap with the right hand, then tap with the left hand, then alternately tap with the right and left hand, then bunting, then catching, then tapping the ball in up gaze, then jumping and tapping, and then using Yoke prism with one of these areas that they're successful with. So what I'm observing is how much prompting is needed to hold their hand flat. The reason why I have their hand flat is to see if they're able to touch with the most sensitive part of their hand. Are they, when they're trying to tap the ball, punching the ball, touching it with their fingers, with the back of their hand, hitting it sideways with their fingers? But I want to see, can they tap it flat? Then can they tap the ball independently, or they need me to touch their fingers to keep that hand flat? How many repetitions can they tap? Are they using just their peripheral vision to tap it, or are they looking at the ball, converging their eyes back and forth to tap the ball? And can they catch with both hands, or are they catching with one, or just catching with the string in their periphery? I also look at their posture. I'm standing behind them, especially if they have some low tone and they need some assistance with holding their hand flat. Are they leaning back into me for grounding? Do we have to have them sitting in order to tap the ball so that they're more grounded, or do they need to lay down so their body is fully grounded and look up and tap? Can they purposely motor tapping the ball with their right and then their left hand? Do they cross midline, or when they're alternately tapping, do they turn their whole body to tap with the right hand, and then tilt their whole body to tap with the left hand to avoid crossing midline? Can they estimate that speed of the ball as it's coming towards them, or do they, seem like they are going to be hit with the ball? Then can they control the speed? Are they hitting it really hard or very, very soft? And do they overshoot or undershoot the ball with bunting and with tapping? I also see, are they able to stand on an uneven surface, such as 1 foot in front, higher than the other, or on a trampoline? Can they jump and tap simultaneously, which is important because that is using both their central vision and their peripheral vision at the same time. As you know, the central vision is what we're discriminating with and being able to converge and diverge our eyes. And fixation, whereas our peripheral vision tells us where our body is in space. And as you're jumping, you're decreased your grounding. And so you have to pay attention to the periphery and the central simultaneously. Can they jump and alternately tap the ball? Can they do it in up gaze? How regulated are they? Are they jumping to help regulate themselves, or is it causing more stimming or avoidance or anxiety? So here is Levi, and I am behind him and helping him with tapping the ball. You can see in the beginning, you want to look at his eyes as well. So I like to videotape the exam so I can look at it later. He's looking at the ball. He's converging and diverging his eyes. He just needs some motor prompting and then alternating. He's using more his peripheral vision than his central vision, and is paying more attention to me helping him tap the ball. But then with catching, he was able to look and then catch the ball by himself. So then I go to using rotating Yoke prisms. As you know, a Yoke prism is where there's two lenses that that's a wedge shaped, where there's a base, which is the thick part, and then the apex, which is the thin part. And a Yoke prism is where the bases are in the same direction. And when worn, depending on the direction of the rotation of the prism, will either move the perception of the world to the left, to the right, up or down, and expand space and constrict space. So what I'm doing with having the prism on is I'm seeing how quickly does the patient adapt to the prism. As you remember, adaptation is one of the parts of Praxis, is that say a person is able to tap the finger with the fast pointing, you put on the prism lenses. Now they, even though the finger's here, their perception of the finger is over to their left, and they may go to the left and then adapt, move their finger towards where the finger actually is. And some people are very slow to adapt, and some are quick to adapt. And I'm also looking at, is it that particular base regulating to the body? Is it have better visual attention, posture, eye movements, performance of the task, and whether they have that ability to do a central task and a peripheral, like tapping the ball and jumping simultaneously. So here is Landry. He's wearing Yoke prism, and I'm having him grounded where he's on standing on the floor. And you can see that he has the ability to look at the ball, converge and diverge his eyes, and tap the ball with good control. Here's the rotation, and I'm putting him on an uneven surface. And you can tell that that prism is not comfortable for him perception-wise, and he's covering his eyes.
Jump.
So then we're trying to get him to jump. We haven't even sent the ball yet, and it's difficult for him to come off the space and jump and tap simultaneously. Then it dysregulated him to where he had to do a lot of jumping to help regulate his body. And then I was able to put on a prism in a different direction to see how that direction helped him. Was it, did he have better fixation, or was he using just his peripheral vision? Is he able to jump again and tap at the same time? And then this prism changed the space so much to where he had to jump very high. That was his response to it. And then this direction of the prism was more regulating to where he's able to jump, converge his eyes, diverge his eyes, and catch at the same time. This is Levi again. We're using the LaBarge electrotherapist, and as you know, as you press the button, it lights up. What I'm first seeing is he able to look and touch at the same time? And that is that visual motor integration that is very important to be able to look and simultaneously touch using a letterboard. Many times, those with apraxia will look at what they want to go to, and then when they look away to touch, and they may end up on the wrong letter that they are desiring. And so what we do in testing and in training is use this instrument to see if they are able to look and touch simultaneously, be able to jump fixate from left to right, like from A to Z on the letterboard, and are they able to cross midline, both with their eyes and with their body. Now he's holding on to my finger. I'm not guiding him, just for his grounding. You can tell his fixation is pretty good, going back and forth. And then we do it with each hand separately. He's anticipating going from left to right, and he just needs some motor support. Now, when we're alternating, he's avoiding crossing midline by moving his body. And so that's something that we would work on in therapy. Then I go to letterboard testing. And this is different than using the letterboard in a spelling session. So how that works is that the CRP sits on the right side of the speller. And if the speller is right-handed, they'll place the letterboard on the right side in the lower right gaze, not crossing midline and not in the center, but in that lower right gaze, because then the speller doesn't have to cross midline, and it's just more of forward poking, up, down, and little bit of left and right. But what I'm looking for in the letterboard is not to see how well they spell, but can they search and look to find the letters. So I may have them just say, poke the letter H, or touch the letter U, or have them spell a simple word, so I can see how their eyes are moving. So
I like how you looked around and searched with your eyes. That was excellent. Now I want you to touch the letter H. It's a little harder. Bless you. That one's hard to find, isn't it? Okay, so I'm gonna help guide you. So let's get your finger ready because you're gonna get it. It's gonna go up, a little higher, and then search back and forth and see which one is the letter H. Over. Yes, you got it. Good. Now the letter S. Nice. And the letter U. That's an O. Oh, that's an O. Yeah, I want a U. Like umbrella. U. You got it. Now let's do a tricky one. Let's do the letter D. Up. Higher. That's the D. Where's the D? There you go.
And the reason why that is difficult is she's fixating with the right eye, and up gaze and right gaze is difficult for her. And we'll find out more when we do her case study. And so that's what I wanted to see is what type of lenses and prisms can help her find and search on the letterboard more efficiently.
I like.
So a lot of doctors and parents ask me, how do I help my speller or my patient wear glasses when they have sensory defensiveness? And so I did learn from many OTs some relaxation and where is my body in space techniques, and that help desensitize the head so that when you put the glasses on, that they keep them on. So one of the first things that we do is massage the hand. Now that palm of the hand is again very sensitive, and so we do a deep pressure, not a light pressure because it's just like being tickled, that's uncomfortable, but a deep pressure on the palm of the hand while they're wearing the glasses. That does two things. It helps with keeping attention that is not on the glasses but on the hand. It also stimulates the palmar reflex, so where that helps with desensitization and where's my body in space. Then we do a series of massaging the arm all the way up to the shoulders and pressing down. And I'm doing this with really deep pressure. And as it comes up the arm, you'll see as you come closer to the head, they become more anxious, and then you come back down. And you may need that, do that a few times before, once you get to the shoulders, then you go to the head and you press on it, and then you come back down. Then when you're introducing the glasses, then you always present it in lower gaze and not in upper gaze, because remember the anxiety increases as you come straight up, but you want them to be able to explore the glasses and touch them so that they see that these aren't something that's going to hurt, that these are something that's going to be helpful for them. And so here's some of the massage techniques on a patient that's getting his first pair of glasses. And then I'm going to model it on myself, that this is what I want to do, is that these glasses go on you. I present it again down lower and model it again. And this time when we put the glasses, he's helping put them on now. So he's getting the idea of this is what they're supposed to be for. And so I'm asking him or letting him know that I'm going to count for 5 seconds, and that's as long as that he needs to have them on. And while he has them on, then I'm pressing that palm again, and I'm counting down to 5 seconds and then taking them off. So now he knows he can trust me that I'm only going to have them on for 5 seconds before he's taking them off. Now I'm counting to 10, and I'm going to use the palm pressure with both hands.
8, 9, 10. All right.
Now I'm getting something that is interesting that he gets to touch and feel to decrease his anxiety, and as well as give him something that is more interesting than taking off the glasses. And then I have the father help with practice, and I found this is a very fun activity for them to do, is counting. And so it can be anything, working on the iPad or singing or doing any kind of things with the hand, and to get him help to wear the glasses. This is Levi again. I didn't do the massage technique. I was just seeing how he was introduction to the frame. And you notice in the video how I'm very regulated in my body. So that's helping him regulate as well. And it also helps him with calming his body. He can tell that he wants to put the glasses on, and he knows that's the purpose. But his body is apraxic and has difficulty with that purposeful motor. How he leans forward into it. And this time I'm doing, a regulation as well as an interesting thing, and looking at the video. And we just do that in a repeat, as long as and give the mom a pair of glasses, a pair of frames that is donated, that's sterilized, so that they can practice at home before he gets his prescription glasses. So the next thing I'd look at is the patient's gait. And what I'm, in this case, the student on the left is walking on his toes. He was referred by his physical therapist because she had been working on massage and stretching techniques to help him with decreasing his toe walking, serial casting, and she wanted to refer to me to see if there was a visual perception problem that was affecting his gait and his ability to walk heel to toe. So you can see this video that his heels do not touch the ground, that he's on his toes. And he's been walking this way. He's 11 years old for as long as he's been walking. And so there's still some constriction in the tendons. And so we did some testing with Yoke prism, and working with the physical therapist with the stretching, and doing different activities of where is my body in space and jumping. And you can see this is after a couple months that he's now with the prism glasses walking heel to toe. And now a few months later, he's not needing the prism glasses anymore for his walking. This is the woman that we saw before with the decreased fixation. I took a video of her gait before she received her glasses. And for the entire time of her life since she's been walking, her mom has had to hold onto her for grounding and to decrease the fall risk as well. Because she's not looking where she is going, and has increase of that awareness of danger. She's not aware of danger. And she sees that she has, she rocks her body a lot forward and back. And then we use the Yoke prism with her. You can see a mom still wants to hold on to her, but you can see her more upright posture, and that she's actually walking and looking around. And now that she has her prescription glasses with some Yoke prism, that she's now walking independently without the rocking. This is Gina, and Gina is described by her parents as very cautious. She's insecure with her surroundings and will hold on to her parents when navigating through space. And so here is her gait. And then we use some Yoke prism in different bases. This is base down, that the stride of her gait has improved in the speed. You'll notice though that she's tilting her body and guiding with the left rather than the right. So this was just a week or two ago that we're going to be using rotating Yoke prism in her therapy to help with that adaptation, and then recheck her gait with the Yoke prism. And we may need to prescribe some Yoke prism in her glasses that has the base down and maybe a horizontal Yoke prism as well to help align her posture as she's walking. So here are some case studies. This is Sophia again. She's 16 years old with cerebral palsy. She had a history of esotropia surgery at age 1 and exotropia surgery at age 3, and she had some patching and vision exercises. She has nystagmus and amblyopia, and she has a higher prescription in her right eye with irregular astigmatism in the right eye that affects her visual acuity, and a lower prescription in the left eye, but that's the amblyopic eye. What you may have deduced from the previous videos is that the right eye has nystagmus, and the null point, or where the velocity of the shaking of her eyes is lowest, in lower left gaze. It is the fixating eye and the main eye, because the left eye, the null point, is in her upper right gaze, and it has a higher velocity even in the null point than the right eye. And when she's viewing a distant object, since the primary eye has the null point down and to the left, she moves her head in posture to look straight ahead, or just looks down while she's walking and is less aware of her periphery. And her when she's looking at a target that is still and her body is still, since the null points are one down and one up, she tilts her head so that they're more even, so it's less confusing. But as soon as the object moves or she moves, the left eye turns out and she's only using her right eye. Now, because this is the null point with her right eye, when she's looking to the right, the nystagmus velocity has increased quite a bit. And so that's one of the reasons why she turns her whole body to avoid looking in that right gaze. And in up gaze, she moves her head all the way back and to the right. So now that you know that, I want you to look at, this is just the left eye, her null point is that upper left gaze, or upper right gaze.
We're gonna do it up here. Bless you.
You see how she gets it right in that corner in order to get the stick in the straw.
You did it. And then we're gonna do.
Now in down gaze, it's also difficult for her because she has to move her head into that null point, which is in up gaze.
Okay. And
Now I want to see how she does with me holding her head. You can see the nystagmus velocity there until she turns her head. She's pulling really hard on my hand to get into that null
you
point.
did it. Time. All right. I'm pretty proud. Okay, so this time we're gonna try to follow it. A little frustrating.
She's using that null point to help follow. It's a very difficult task for her.
You don't get it in,
She's
it's
got it
okay.
in up gaze, but as soon as she goes in down gaze, then she's just anticipating that the straw is going to be moving because she's unable to fixate on it.
What you gonna do? You're making the circle like I want to, but I want you to look at this part here. Okay, there it goes. Keep tracking it. I know it's fine.
And now with the right eye, you'll see that null point is in lower left gaze. that she's moving her whole head and body to try to get within that null point. But you'll see that the nystagmus increases quite a bit when she's looking in right gaze, and she's moving her whole body to get at least closer to a null point. And then up gaze, you see the nystagmus is much larger velocity. And she's trying to pull her head back as hard as she can.
We're gonna do it down here. I'm gonna move your head up. There you go.
And she's able to fixate better
When
and
we
lower
like the
gaze.
most, the one where I have.
Now, when we're trying to do the pursuit, as you can imagine, in right gaze, she doesn't have perception of where it is in relation to the straw. But as it gets towards her null point, she's better, and then she knows, anticipating that it's going to keep going around and around. Which she does in her everyday life. She's anticipating movements because her eyes aren't giving her reliable information. So we did give her a prescription that's specific for spelling, and that I used Yoke base right as well as base up to help her navigate the letterboard better to where she can see the letters that are on the right side and on the upper area. And that helped her when the letterboard was in down left gaze as well. I gave her some recommendations for her school is to put her communication device, her keyboard, the computer, and the letterboard in that lower left gaze so that right eye is right at the null point. When her parents and her teachers are speaking to her, is to be a little lower to them in that lower left gaze so that she doesn't have to have an awkward position of her body when she's using a computer, as well as that she sits high in a chair and the computer screen is lowered and to the left. And then the print of her schoolwork should be larger with double spacing between words because of the crowding effect. So now we're going to be testing, this was just briefly this last week, how she is walking. Now, how Sophia walks is that she started to walk independently, I think at age 13. And as she was walking, she gets the velocity going, but she's using that right eye to look down and to her left. And then trying to be aware of that periphery. But then she falls forward when she stops, unless she goes and touches a wall or a person. So then I put Yoke prism to see if she was more upright and able to look at me when she was walking. You can see now she has her head in a better posture. And we're going to be retesting that this week again, because we had limited time this last week. And before we do a prescription that's specifically for her walking and for her computer, which is straight ahead in some cases when she's doing her online classes. So this is Brady. He is a 20-year-old man with Down syndrome and apraxia. He is an open communicator on his letterboard, and he communicated that he saw double and multiple letters on his letterboard. He saw that he needs to rock his body forward to get the letters that are overlapping to separate. He has an intermittent left esotropia with irregular stigmatism on that left eye, that restriction of upgaze that we saw in his other videos, and diplopia both at near and far, and with accommodated insufficiency. So I gave him a spectacle RX with compensating prism of base out that helped him see single both near and far with some accommodative add in his prescription. And so this is him on his letterboard before we changed those glasses.
And keep going. And go, 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 go. Find it, find it, find it. All the way down.
You can see he needs some motor prompting, and he does the rocking forward and back.
You got it. Right next door.
And then we put his prescription with the compensating prism and the focus to be at the letterboard.
Big,
And he was more accurate with his letterboard. So when he got his new glasses, he said, my vision is much clearer with his new prescription. And he also spelled, it's hard to look straight up. So he was noticing that too. And that the rocking helps lift his distant sight. And then when he leans forward, then the sight matches up. So that was what he was saying corresponded to what we were seeing in the exam. So we did a home therapy program. He doesn't live close by, so we sent home a program for him to work on with rotating Yoke prism, with the Marsden ball, the stick and straw, in different fields of gaze. A lot of things that are in up gaze and fast pointing. And I'm going to show you some of these activities in the video. So this one, we're looking at his standing balance, first with both feet on the ground where he's grounded, and doing a central toss with the stick and the straw. There we go. And he's been practicing, so see, he's getting an up gaze better. Now I made it a little bit more unsteady by putting one foot on a beam, but he was able to look both in straight ahead and up gaze pretty well. So then I switched feet, and you can see his stability is much different. Even though he's able to perform the task, he's trying to get that core and that peripheral vision to work with his central vision. So then we moved to a trampoline, and which is more unstable, to see if he can do just a large visual motor activity like tapping my hand in different fields of gaze while he is either standing, jumping, or doing little jumps. And he needed my support by holding on to one hand in order to get him off the floor and decrease his grounding. And this is the start. This is where we need to start with his vision therapy until we move on to a smaller target like a Marsden ball while tapping, while jumping.
just hit my hand. Hit my hand.
And you can see he's avoiding that up gaze now because he's unstable.
I'll hold this hand.
Now he can jump since I'm giving him some grounding, even little jumps. But in up gaze, you'll see that it's a little harder for him. He's not looking, he's using his peripheral vision. But he's engaged, which is great. Then I wanted to see how, with his new glasses that have the compensating prism, how is his visual saccades in the distance and location of his fixation. So I just put a random series of letters and numbers on the wall and gave him a laser pointer, and calling out the letter out of order to see if he's able to point to that that letter. We started with big letters, and this is one that we switched to smaller letters.
3, 4, 9, 6, B, M. Okay, so I want you to point to the letter C. Now the letter M, B, 4, 6, 9.
Yeah, dude.
Which is awesome. So now we're looking at the letterboards themselves. When we're looking at the letterboard on the right, that's the one that he came in with. You can see that the letters are very large and very closely spaced. And we know as optometrists that when you have esotropia or exotropia or any kind of strabismus or amblyopia, that because of the crowding effect, it's very difficult to find targets that are in the center. So I recommended that his letterboard have smaller letters because you can see those, but with more spacing in between. And then his mom made different letterboards to see which one was visually more comfortable for him. And he chose the next one, which is a white on black background. So then after 3 months of home therapy, his eye teaming improved so much that we were able to remake his lenses to where he had less prism. And then we also prescribed a second pair of spelling glasses, and we had to make some adjustments on those two just for the right focal point without prism. So Landry is the 10-year-old boy that was on the trampoline with the prism, and his parents made up a letterboard that I suggested to do like in a spiral. Remember when we're doing a heart chart or a four-corner saccades where the outer letters are easier to find and the inner letters, it's a bit more confusing. So to help with that and accommodate for that, I suggested to put the outer letters in a different color than the next row and then have the M as a centering letter. And when he went back home and used the letterboard with the CRP, he said that he had one of his best spelling days, and he was so accurate. And he even, as a 10-year-old boy, spelled the letter enigma, which I thought was great. So this is Gina again. She is the one that occasionally gets stuck and is very cautious. She has a good sense of humor, but since her verbal communication is difficult, she has difficulty with social interaction and has challenges maintaining eye contact on a person or a task. So we did using the multi-matrix scanning where there's different dice that have numbers on it, and then that are white, and then she has to look around and find the matching letter number that is on the colored dice.
Okay, here's the next number.
So this works great for looking and scanning that you need to do for working on the letterboard. You can see she is very good about looking at all of her choices, left and right, in an orderly fashion before she found the
job.
numbers in her periphery. Now, you remember with Gina, she's very cautious and she moves at a slower speed. And so what I wanted to see with the LaBarge is to see if she could regulate her body to and her motor movements to go a little faster according to the metronome. And so it's an auditory visual motor integration task. And we'll take a look. I first tapped it according to the beat to give her a visual of what the beat looks like.
Okay. Yeah. Good.
You see the last ones were more accurate.
Okay.
And then I changed it to a faster speed. And I wanted to see if she was able to listen to that and change her speed of touching. I helped her for the first few. But she was able to, which is excellent. So part of her therapy with that instrument is to go faster and slower so that she can regulate her motor movements to be faster and slower as needed. Now, this next therapy activity is using a flashlight that's behind the board where she has to move the flashlight, which shows it red on the front, through the maze as she's going through. So it's a ocular motor and a visual motor integration task. And she's not being able to look at her hands, so she has to be aware of where her body is in space. That actually is quite complex. And she was good until she got to the bottom, and then she went the other direction. And so she was redirected to go back up, and then she did really well getting through the maze again with good tracking. Now, this is the SVI unit that one of the programs is a rotator where the dots that are on within that circle will move, and we can change the size of the dots and the speed. So this is the first time that she's used it. So we have the rotation at a very slow speed and the dots as being big. So her accuracy doesn't have to be as good as if the dots were smaller. And she first has to touch the center to start it, and then she'll start touching the dots. Now we have her standing off to the side so that you can see the dots moving for the video, but we would actually during the therapy have her centered to where she's having to cross midline too. Our next patient is Hudson. He's a 12-year-old autistic boy with apraxia, and he also has very low tone. His mother said that it takes him a substantial amount of energy to initiate that motor movement. But once he gets going, then he has poor force grading. He will, when he's using his letterboard, hit it very hard. He communicates through his spelling that I wobble in my sight, and that makes sense because he has an intermittent V pattern exotropia. And so he does not live close by either. So we do Zoom vision therapy with him. And so this is him with his parents on the left, as well as our therapist who's on the right, guiding with their vision therapy. And I'll let you listen to this.
Here it comes. 3, 2, 1.
Now you can see how he's not estimating the speed of it. His dad is counting down.
A little bit, let him just look at it at this point. Let's see how he interacts with that.
So the beauty of having a ball on a pendulum is that then you're able to start to estimate speed and also know that it's not going to hit him.
Gauge the velocity.
And he's sitting because he has low tone and needs more grounding. First doing a visual
used to the
test.
fact that it's not going to hit you.
And then he was able to estimate that speed to grab it. Now he's able to tap the ball and catch it while standing, which is excellent. Now this is him working with his dad and putting, instead of a stick in a straw, he's putting an Allen wrench in a metal tube, which I think is genius because he's able to hear the clicking of him being successful putting the stick in the tube.
Good work.
Good job, buddy.
Let's do it with this one. I know this is hard. Forth a little bit.
Now we're doing a pursuit in upgaze. Remember, he's a V pattern exotropia.
Nice.
And so it's difficult in upgaze. And so he's going a little higher. You can see how much energy it takes for him to start that, initiate that motor movement.
Come on, get it there.
And the strength that it takes for him to maintain that fixin long enough to get that stick in the tube.
Nice.
Okay.
Good
Good job, buddy.
And how happy he is that he did a great job. So the last patient is Samuel. He is a 20-year-old autistic man with cerebral palsy. He is an open speller and has been writing a few books of poems. And he uses 3 letterboards for lessons and is an open speller for 26 letterboard. He has an intermittent left esotropia, and he can maintain his binocular vision for short periods of time with vestibular input of his head moving side to side or up and down. And so we use that in his therapy, using that vestibular system to help drive that binocular vision system to work better. I didn't get a video of this, but we did do pull tube testing with him to where he wasn't able to grip onto the pull tube, just like Max that we saw earlier, who has low tone. So we did a massage technique where we rubbed the palm of his hand with a deep pressure, then also rubbed his fingers to give him feedback of this is where my fingers are in space, and especially the center part of his pointer finger, which is one of the most sensitive fingers next to the pinky. And then after the massage, then I had him hold on to the pull tube, where now he would actually have the strength to hold it on to where I could pull the pull tube. And you can see as he was having that bilateral coordination, that his eyes also coordinated together better, and he was able to fixate better. So I also gave him the option of using a color-coded letterboard. And so it would be easier for him to locate the letters on a 26 board, as well as his 3 boards. And he found the colors were more regulating and the stripes were easier to find the letters. So this is his very first vision therapy session that we did last week, I believe. And we first started with stretching the whole arm up, because if you get first the whole arm of where's my arm in space, then he's able to lift it a little bit to do his spelling. And what we're looking at with the Marsden ball is his ability to touch the ball and look at it simultaneous, which is very difficult for him. He was able to catch it in his peripheral vision. And I'm having to help hand over hand assistance to look at it. And I'm mainly looking how long he's able to fixate on the ball. Now I'm looking at him just pursuing the ball with touching it, without touching it. And then he didn't have fixation. Then I put some Yoke prism on that was dysregulating and didn't improve fixation. So then I changed the rotation of the lenses and did the same task with touching. And he had slightly better fixation for a short period of time. But then even that lens became dysregulating as well. And now with the next rotation, you can see his fixation was much better. He does have a big lag in his ability to maintain the pursuit with the speed of the ball, but he's getting that fixation in longer periods of time. So we used the base left prism that gave him the best fixation during his spelling sessions with his CRPs. And I also recommended the sensory learning program, which I have on my YouTube channel, a whole webinar on how this works. But briefly, the patient lays on a bed that rotates up and down and side to side. And the patient's looking up at a light source, which is using the syntonic phototherapy to help regulate the autonomic nervous system while stimulating the vestibular system. It's also, after you've been on the table, it's done in complete darkness other than the light. It feels like you're not moving, but the light is moving. So it works on visual pursuit and also convergence and divergence. And it has an auditory component as well. So it's a multi-system training that helps with regulation. So this is him spelling with his CRP after the sensory learning program and with the color-coded letterboards. What he's spelling is Princeton. It was one of the answers to the lesson. And so she first did the stretching first. But see how his fixation is much better. He's not just looking and looking away like he did before. And she's coaching him to lift his hand.
Next letter is go, go, go. Find it, eyes on it. Get your eyes there. Eyes T, then. Next letter is go, go, go. O, and N. Nice, beautiful.
Great. So he wrote to his mom after we were talking about the sensory learning program, whether she wanted to do it for him or not. And he wrote, "Mom, I have to tell you how much I appreciate your courage. I have DM, who is his CRP, and God, he strengthens me like he does everyone. Fear not, Mom." And his CRP wrote, "Is this specific or general words of wisdom?" And he wrote, "Specific to seeing Susan Daniel," which was really awesome. So I want to give a big thank you to all my spellers and to thank my mentors, Don Marie Gavin, Dr. Dana Johnson, who are the founders of the Spelling Center, both in Oceanside, California and in Tampa, Florida, and Brooke Poston, who is my son's CRP. You can find other practitioners in your area by going to the website www.i-asc.org. And I also wanted to tell you there is a movie that is coming out the end of this month, and it's having some, it's in Phoenix at a theater for its premiere, and then there's some private showings. So if anybody is interested in seeing a private showing online, then I can set you up with that. But it tells the story of 8 different spellers, 2 of them who are my patients, and it's inspired by the book Underestimated. You can see if you want to have a group of people watch the movie, you can go to spellersthemovie.com and sign up to have your own private screening. So thank you very much. And if you have any questions, you can email me at drsusdan@pacbell, which is PACBELL.net. So thank you very much.
Thank you so much, Susan, for doing this. When I send the recording, I will make sure that I include you in a copy so that people have your address and can email you directly. But thank you so much for doing this. It's a marvelous presentation. It's very rich. It's incredibly, I would say, spellbinding, but now I'm playing on words. But thank you again for doing this for us.
Thank you very, very much.
So if you agree, I'm going to stop the recording now.
Okay, thank you.